Good evening, everyone. So this is a very basic talk for postgraduates. So what is ideal PRP? We all know that how the laser is to be done. If we take the area, nasally it should be done up to 500 microns. Temporally it should be 3000 microns away from the disc. Superior and inferior you should do up to the temporal arcades. Distance is approximately 1 burn width apart. The main important thing to learn is that we should always laser the inferior retina first, because many a times after doing the laser there are chances of vitreous hemorrhage. So if you do the inferior retina first, then you are able to complete the PRP in one sitting only. So what are the reasons for incomplete PRP? The most common reason is a beginner. Yes, they are very known, and the media haze. So beginners, yes, because of the vitreous hemorrhage, or even if there is no media haze, then there are more chances that there will be skip areas while doing the PRP. The type of the laser you are using. There are mainly two types of lasers which are being used, green laser and the red laser. So it is known that the green laser has a poor penetration, especially in cases when there is a media haze in form of nuclear sclerosis or vitreous hemorrhage. And in such cases, red laser is always preferred. Laser delivery system also is one of the factor. If you are using 3-mirror gonioscopy lens on the slit lamp system, then there are more chances of skip areas which occurs in the areas between the different mirrors. So in such cases, you can use the panfundoscopic lenses or the Menster wide field lenses, in which in a single mirror you can cover the full retina. LIO delivery system is preferred in cases of media haze, but the main disadvantage is it has a long learning curve. Now, how to tackle the media hazes? So these are the various situations which you can get along with the various, in cases of PDR or any other thing when there is media haze. So in cases of corneal edema, you can manage it with the hypertonic solutions. You can use epithelial scraping or the anti-glaucoma medications, or even the surgery, and you have to reduce the corneal edema first, and then you can go for the lasers. In cases of small pupil, you can use 28 diopter lens instead of 20 diopter lens. You can atropinize the eye, or you can also take the laser pupilloplasty, so that you can increase the size of the pupil and you can do the lasers. So in cases of cataract, LIO delivery system is preferred. Red lasers are preferred, and if you use the more energy, you can do the panretinal photocoagulation. But if you feel like that the media haze is significant and none of the methods are able to, you can complete the PRP, then we should first go for the surgery and then do the panretinal photocoagulation. In cases of vitreous hemorrhage, yes, I already told, always do the inferior retina first. Always titrate the energy according to the amount of the vitreous hemorrhage and also the area you are doing. And in such cases also, the preferred laser is the red laser. So this is a case which was presented at the presentation. After 2 weeks, there was reduction in the vitreous hemorrhage with just conservative management, and then the stepwise laser was done. As the vitreous hemorrhage was clearing, the areas were lasered. Another thing is the anti-VEGFs in the vitreous hemorrhage. So there are two studies, protocol S and the Clarity, but the main prerequisite for giving anti-VEGF in vitreous hemorrhage is that there should be no traction. So which should be confirmed on B scan. So this was a case of vitreous hemorrhage, B scan was done, there was no obvious traction, so the anti-VEGF was given. So after 1 week of anti-VEGF, this was the picture. Then 2 weeks later, there was further reduction in the vitreous hemorrhage, and in such case, then the laser was done. Choroidals happens with the number of spots you are using. It happens more commonly with the eyes with the shorter axial length, and if you treat more area in single setting. In such cases, just defer the laser till the choroidal subsides, and you can also use topical steroids and mydriatics for the earlier resolution of the choroidals. In cases of PDR with traction retinal detachment, always do the laser 1 to 2 diopters away from the traction. Your goal should be the regression of the vessels, but if you still feel that the disease is progressing, you should always go for the surgery. In cases of neovascular glaucoma, first reduce the pressure and the media haze by the use of steroids, anti-glaucoma medications, anti-VEGFs. We still don't know whether they help or not, or we should adopt this method or not. In case by any of the method it is not possible to complete the laser, or the disease is progressing, or the neovascular glaucoma is uncontrolled, we should always opt for the vitrectomy in such cases. So this was the case. Laser was done. There was, in the superior temporal arcade, there was minimal traction, but non-resolving vitreous hemorrhage. So after doing the vitrectomy, you can complete the laser on table also. Now, when to do the laser up to ora serrata? In cases when you need to do the fill-in lasers, if there is significant skip area, you should do the lasers immediately. But if you feel that the laser was done adequately, but the disease didn't regress, then after 3 to 4 months of the initial PRP, you have to do the fill-in laser. In cases of aggressive diseases, when there is multiple NVEs, then you should always opt for aggressive laser up to the ora serrata. In cases of neovascular glaucoma, post vitrectomy also, many a times when there are no iatrogenic breaks, the fluid persists, which automatically get resolved after a period of time. So after removing the membranes, you should not always opt for doing the laser, as the laser per se you can cause the iatrogenic breaks. So in such cases, let the fluid get absorbed and then you complete the laser. So these are the two cases which are being presented here. So to conclude, always go step by step in case of difficult situations. Tighter the laser energy depending upon the situation. Anti-VEGF should be used judiciously, and in case of progressive disease, don't wait. Surgical management is the option. Thank you.
Thank you, Dr. Shilpi. I think this is very important, how to do laser and how we should proceed. What my questions to you is, in present time, in case you have a high-risk PDR, you don't have proliferation of what you call tractions or other things. So do you give anti-VEGF before you start PRP?
Sir, if media is clear, we don't give anti-VEGF.
So you see why I asked this question. I think this trend is catching up. In such cases, if you do that, I think you have a more safety profile, as well as you can do much more laser everywhere, wherever you want. Because, and then in such cases, we have seen in past that they do bleed at times when you are doing laser in these cases. So I think in that case, those cases, maybe if we can use even if you don't have anything, you use Avastin, which works very well, which is the best in fact for new vessels. So, and then you do PRP, they may do much better. Of course, you can use biosimilars or whatever, any other, because if in case there is a fear of having infections and other issues. And second thing, what you said is about the type of lasers. I think red laser is hardly used. Don't take from the studies done by us, especially on ROP. You see, first laser for ROP, we got with great difficulty way back in 1997. And once that laser conked off, I didn't know what to do. So I started using 532, and which was contraindicated. And since we had substantial cases, we presented in American Academy. They took in writing from me to present that poster, because they said we are doing something which is not done. So I gave in writing. I was confident we had good, and I knew they'll not publish that. They didn't publish in ophthalmology. Finally it was published in British Journal. But what I'm saying is why I brought it. That changed the whole practice. You use 532 laser for ROP. So same laser can be used for everything. So I'm talking from economics point of view also. So I think it works very well with vitreous hemorrhage as well as pre-retinal hemorrhage and little cataract and other things. And since we have anti-VEGF these days, so we can always tide over that. And if we tide over that, as you said yourself, even the cataract surgery can be done because you have anti-VEGF, and then you can subsequently even laser early with LIO rather than putting in a lens sometime, which may not be.
Yes.
I have only one laser, 532, for last 18 years, and I do everything with that.
I think most.
ROP, endo laser,
green laser, sir,
slit
but
lamps.
it is just
Yes.
those who have the facilities of suppose both the lasers.
Actually, that is what you are right, because this targeted photocoagulation concept which came up with that, and also with wide field angiography. It's not only that, so because wide field is available, as well as those kind of lasers were available where you could do that. But you see, the question is whether how much practical, how many people have wide field angiography. Once you don't have that, you won't be able to find out that area. So I think if we stick to a good pan-retinal photocoagulation, which is traditional, I think that is way we should go at this time. Down the line, once we have more of these machines available, because that wide field would be required. You won't be able to get otherwise selective area to do that. So I think at this time it is too premature. That's how this targeted thing has not really caught up that much, even in the Western world.
One point, ma'am, according to the context of the presentation, incomplete PRP. So what, in my short experience also, what I've learned is that even with a wide field lens, your PRP is not complete. Because there's still a disc or 2 disc diameter area that the wide field lens cannot reach up to the aura. That because the ultra wide field angiography and all these modalities have showed us that that peripheral CNP area is still left, and that can be a cause of a DME or even recurrence or hemorrhaging. So maybe addition, what I normally do is I add also with an LIO and with all clock hours examination, so that examines as well as I'm able to laser that area as well.
So usually what we do is, in a primary setting, we never do up to the ora serrata. If it is a non-resolving case, then only we do up to the ora serrata.
So what I normally do is I just do a slit lamp 3 sittings standard PRP, and especially for patients who are young and who have PDR, I just do as anterior as possible and leave the area up to even up to the equator, so that their field is not that much lost. So I just complete about 3000 spots, and then after that I think we just need to titrate with the disease, whether the disease is progressing or not. So if you still have neovascularizations, then you need to keep adding, and wherever, maybe anteriorly or even posteriorly. So sometimes we need to do 5, 6, 7 sittings also in these patients. I hope Dr. Dokra will agree with me, sir, because I am not doing like anti-VEGFs for PRP, because that's also one concept which has been there in Western world, that to keep doing anti-VEGFs for PDR. So, but in India, I'm not a votary for kind of anti-VEGF injections for PDR. Of course, it is there for DME.
Yeah, I think those repeated injections are different. What, in fact, don't look at the new vessels. They may stay there forever and never bleed. You see, these are now the mature vessels you have found out, so don't chase them. So for that sake, don't keep on doing repeated PRP until unless they start leaking. Patient is complaining of those black-like spots coming, or you see some small hemorrhage. Otherwise, you will keep on treating the whole retina, and it will become tubular, and you will become don't do that. So the PRP doesn't mean that we have to do excess. PRP means you have to do enough. So from my point of view, it's never like what Dinesh mentioned, 3000. It can vary anywhere from 1200, 1400 to even what he mentioned, 3000, because it is going to be variable for every patient. It's not going to be one shoe fitting everything. So that's the way we proceed.